Thank you very much, Lorenzo, and thank you also for the invitation. It's very nice to have the chance to present results from a study of COVID-19 and vaccination rates in Germany. And well, to briefly introduce myself, I am a radiation epidemiologist. So actually, I don't normally do COVID-19 studies, and we do not have any funding for these. So it is a spare time project, basically, that we did because we had access to what we think was interesting data. And I think we were able to contribute a little bit on the knowledge about the COVID-19 epidemic. But as I said, it's normally I do, for example, late effects after radiotherapy, mainly in breast cancer, in patients with breast cancer, and but also in children with cancer treatment and children with CT scans, for example. So that's the type of study that I usually do. But today I want to talk about this study on COVID-19 and vaccination, and this is a collaboration with Emilio Gianicolo and Maria Blättner from our institute, but also with Melissa Schöps, Nils Herm-Stapelberg, and Ruben Hamann from the Division of Vaccine Documentation at the Rhineland-Palatinate Cancer Registry. And so what is this about? Well, basically, we were interested in real-world data on vaccine efficacy. And while some might say we have all these very highly controlled, randomized clinical studies, blinded and randomized treatment arms with placebo controls. And we've clearly seen the efficacy of the vaccinations that are currently on the market. So the question might be, why do we need an epidemiological study on real world data anyway? I mean, the efficacy has been shown. So why do another study on this? And to you, the answer might be more obvious than, for example, to others, to politicians, for example. But what we think is that when the vaccination campaign started in Germany in early 2021, we only had data on the vaccine itself, but the effect of a vaccination campaign as a public health measure is not the same. Because, for example, clinical trials are more selective with respect to who can participate. There are certain exclusion criteria, often related to comorbidities. So the participants in clinical trials may not always be 100% representative of the population. Another point was that since the participants in a clinical trial do not know in which trial arm they are, they do not change their behavior based on knowledge if they are vaccinated or not. However, in the real world, people know that they are vaccinated or that they are not vaccinated. And as a result, they might change their behavior. For example, it could, theoretically, people might compensate any additional protection from the vaccination by showing higher risk behavior. For example, having more social contacts, not wearing masks, and so on and so forth. And that's why we were interested in the effect of the vaccination campaign as a public health measure. And how we approached this was as follows. So in the beginning of 2021, when the vaccination campaign started in Germany, the vaccines were very rare. So the supply was very limited. And that's why there was a priority scheme. And I don't know, this might have been the same in Italy, but in Germany, so the first with the highest priority were people over the age of 80 years, together with healthcare workers. But the largest group in the population were those age 80 and above. And since vaccine supply was limited, everything was organized by the federal state, meaning that there were no private practices with their own vaccines, but everything was distributed through the state. As such, there was very good accounting on who was getting vaccinated and who wasn't. And this was organized by a special division, the Division for Vaccination Documentation at the Rhineland-Palatinate Cancer Registry, because they know how to handle these registry stuffs. And therefore, for the first half of 2021, this division had almost complete data on every person, every single person that was getting vaccinated in Rhineland-Palatinate. And as a result, we have a data set, we had access to a data set from slightly over 1 million individuals, which is above 25% of the population in Rhineland-Palatinate. So Rhineland-Palatinate has a population of 4 million approximately. And the data set had information from 1 million people who got vaccinated in the first half of 2021, roughly. And among them, almost 600,000 had, roughly speaking, 2 vaccinations, so were fully vaccinated if we use the criteria at that time. So that was basically the data we started with. And then what we did is we combined the data by aggregating it in terms of age group and sex and linking it with data from the statistical office on the population in Rhineland-Palatinate. And the goal of this linking was to calculate the vaccination coverage by week, by calendar week, by age group and sex. And so we got the population from the statistical office. We had the number of people vaccinated, for example, in the age group 80 plus, female 80 plus in calendar week 13. And so we were able to calculate the proportion of the population who was vaccinated at that time. That was basically the first half of the data set we had. The second half came from the Robert Koch Institute, which is the central public health institute in Germany. You may already know it. And they keep track on all registered COVID-19 infection or SARS-CoV-2 infections and COVID-19 deaths, as far as they know, obviously. So as far as reports come in, that's an obvious limitation. But they are the facility that keep track of everything COVID in a sense, and everything has to be reported. There's a law that everything COVID has to be reported to the Robert Koch Institute. And they publish data, also aggregated by age group and sex. And this allows us to link the COVID-19 deaths per week, per age group and sex, with the vaccination rate in Rhineland-Palatinate. And so that's what we did. And our study question was basically on the vaccine efficacy. And we turned this study question into the statistical question whether the COVID-19 death rate was in any way sort of associated with vaccination. And more precisely, we asked whether the age group's proportion among the COVID-19 fatalities was associated with vaccination coverage in a binomial logistic regression model. And this, at first sight, you may ask yourself, well, doesn't this sound a little bit complicated? So why not do like a Poisson regression for the COVID-19 mortality rate and use COVID-19 vaccination coverage as a predictor, as a covariate? And we didn't do that. Instead, we had this a little bit more complicated, less straightforward model where the dependent variable, the outcome, was the age group's proportion among the COVID-19 fatalities. And I will explain why in a second. So going back to the early 2021, this is what the COVID-19 fatality rate per 100,000 looked like for the age group 80 plus. And I don't know how it was in Italy. In Germany, the winter 2021 was quite bad in terms of COVID-19 fatalities. So there was high excess mortality. There were a lot of COVID-19 fatalities in December 2020 and in January 2021. And what you see here is that in the first week of 2021, we had 200 deaths in the age group 80 plus. That corresponds to about 70 per 100,000 population as a rate. And then in the next few weeks, the COVID-19 fatalities declined sharply, meaning that the wave, the COVID-19 wave, was basically phasing out for reasons unknown. We don't really have to know the reasons. What is important here is that the vaccination campaign started in the first few weeks of January 2021, so about the same time as the wave was declining. And there could not have been a causal association because the vaccine supply was limited, so there were not a lot of vaccinations done in the first 4 weeks. And so any decline in the mortality in the first few weeks was not linked or could not be causally linked to the vaccination campaign. There was not enough time, basically. And then we were afraid that if we, just did a Poisson regression with COVID-19 mortality rate as the outcome and vaccination rate as the predictor, we would see a spurious correlation because both were connected to time, to calendar week, basically. And that's why we did not do the most straightforward analysis that you might imagine. But that's why we did something more complicated, and I will explain this in a second. And the other point that I want to draw your attention to here is the bump again. So it goes up a little bit around Easter. So because supposedly you might have more mobility, more social contacts around Easter. So that's where COVID-19 deaths increased again to some extent. So this is what the situation, what the data looked like for all age groups we considered. You see that in age group 60 to 79, there was also a decline in the COVID-19 fatality rate. And since that age group did not get vaccinated until later in that year, this decline could also not have been associated with vaccination. And what you also see is that basically younger age groups below 60 do not play a role at all in the fatalities. What's important here is that now if you add up those numbers, the absolute numbers for COVID-19 fatalities, you have 200 in the age group 80 plus, you have 79 from 60 to 79, and you have 6 in the age group 35 to 59. So in total, you have 285 fatalities. And among those, 200 were in the age group 80 plus. And that is exactly the proportion that we were basically analyzing as the outcome. That proportion 200 out of 285. And this is how that proportion developed over the first half of 2021 for the age group 80 plus. So that's like the orange line that starts at about 70% in the first week and drops to about 9% in the last week, and that is, I think, calendar week 20, where we had only 11 fatalities in total among all age groups, and one of those fatalities was from the age group 80 plus. And this proportion was our outcome. What you also see is that basically there were some bumps going up and down. So for example, in calendar week 19, we had 7 of 13 fatalities in this age group. But as the absolute number of fatalities declined, you expect more variance in the proportion. So basically the data was getting noisier towards the end because the absolute numbers dropped. What you also see in this picture as the light gray and dark gray shaded regions is the proportion of people fully vaccinated or partially vaccinated in this age group. So what you see is that there was in January, there was an initial trend upward. That was like the first batch of vaccines that got delivered to Rhineland-Palatinate. And then there was a shortage in vaccines. So that's why the proportion vaccinated had a plateau until about March, mid-March or early March. And then there was a new supply in vaccines and the age group 80 plus got vaccinated. And so you have a rapid uptake in the vaccination proportion basically among this age group. And during that time, you have a more or less constant decline in the proportion of the age group 80 plus among COVID-19 fatalities. So for the other age groups, that's what it looks like. So when the age group 80 plus has a declining share, a declining proportion among COVID-19 deaths, then other age groups must have an increasing proportion. And the age group with the increasing proportion was the age group from 60 to 79. So basically, this age group was not vaccinated. It did not have high priority. It got vaccinated, as you can see, late April for the first time, but the proportion fully vaccinated was still below 20% after half a year or so. So that's what it looks like for all the age groups. And what's important here is that we can now see, that's the statistical test we did for the association of this age group proportion among COVID-19 fatalities with vaccination rate. And we got a odds ratio for each 5 percentage point fully vaccination coverage of 0.89. And that was statistically significant. So we had a statistically significant association between vaccination coverage and the share of the age group's share among the COVID-19 fatalities. That was basically the main result. That was the result to our main hypothesis. We also did another analysis not relating to COVID-19 deaths, but to infections. So same logic here. What you see here is the reported infection rate, if you will. So the rate of reported positive tests. There might be, not reported infections, as we know, but this is basically the time trend of infections, of reported infections in the age groups. And what you see is that for the age group 80 plus at the lower right, there is a very steep decline in the early weeks of 2021, and then there is a plateau. And for the other age groups, you see an early decline as well, but then it goes up dramatically again towards Easter. And so you could already from this picture, you see that the age group 80 plus has a different behavior with respect to infection rates on Easter. So in all other age groups towards Easter, infections were going up, but not in age group 80 plus, at least not dramatically so. Doing the same type of analysis again, so asking for the share of the age group 80 plus among all infections, it declined, and this decline was again statistically associated with the vaccination coverage. As you might expect, if you assume that the decline in COVID-19 deaths was mainly driven by a reduction in infections. And so that would be consistent with our results here. As a sensitivity analysis, we did the same analysis, but not using a COVID-19 specific endpoint, but using overall all-cause mortality, where we did not expect any type of effect of the vaccination. And that was indeed the case. So switching from a COVID-19 specific endpoint to all-cause mortality did not show any association of vaccination coverage. So basically, the changes in the proportion of the age group 80 plus among all deaths was not associated with vaccination coverage. That was kind of like a negative test in a sense. Okay, so that was these were our main results. Some discussion on this. So we showed that the proportion of 80 plus year olds among the COVID-19 fatalities declined from January to May 2021, and this was associated with increasing vaccination coverage. Our results are consistent with vaccine efficacy, from real-world data in a real-world vaccination campaign. However, obvious to you, we have limitations in the study. The first limitation comes from the ecological design. So we used aggregated data because of data protection issues. We could not do an individual linkage of each person's vaccination status, for example, with a COVID-19 death. That was not possible. So we had to use aggregated data. And as such, it is possible, as in all ecological studies, that we have a spurious association. What's also important is that the time period where we can make a statement on is limited to the first half of 2021, because we now have different virus variants and the vaccine efficacy could be different. And basically, the pandemic has changed a lot in the last year. So we can only make a statement on the first half of 2021. There may be other relevant limitations that we could talk about in the discussion. Other relevant aspects include that this is the first and, as far as I know, currently only study of vaccine efficacy in Germany. And what it has shown to us is that it can be very beneficial to have a good cooperation between the university where we come from and other public institutions. For example, the Statistical Office Rhineland-Palatinate is basic part of public administration, but it was very good to get information from them and also for other studies. So we have a nice cooperation that enabled this study basically. And what's also nice is, I think, the change in policy towards making data publicly available. Before the pandemic, a lot of institutions in Germany collected data but did not really publish them. And I know from Emilio Gianicolo that Italy has a better culture in this respect. So he showed me public data, very detailed, interesting public data going back years from ESTAT, I think, and other institutions. So this has become a little bit better in Germany in the meantime. Okay, so that was basically my talk on the study itself. And then, since Lorenzo mentioned that the contact with politicians could be also interesting to you, what happened was that after the study got published, we were happy, and because the division of the vaccination documentation gets funded by the state, we did a press release basically as a show to show the public administration that we were doing good things with their money. And so the press release was to help the vaccination documentation division to basically show to those who spent the money, yeah, we're using the data, we're using your money to do good stuff, basically. And so we did the press release, and it had some news coverage, but not too much. And so that was it, or that was what we thought. But then a couple of days later, I got an email from the assistant of the prime minister of our federal state, Malu Dreyer, asking me if I wanted to present my study in a press conference together with the prime minister 3 days later. And so the background was that, and that was late January 2022, so this year. And so the background is that in Germany, we do have a very hot discussion on mandatory vaccination. And I know that in Italy, it is probably very similar. And currently in Germany, there is not a majority in favor of mandatory vaccination. And so every couple of weeks, the prime ministers of the 16 federal states, they meet and they make decisions on new public health measures, basically impose distancing rules, or if schools have to be closed or something. And after each of these meetings, they do a press conference where they present what they have decided on, what new measures will be implemented. And I was invited to the press conference of one of these, after one of these meetings. The press conference was an hour, and the prime minister talked for 10 minutes, and I also had 10 minutes to present my study. And from the beginning, it was pretty clear that, this was a deal. Basically, we were getting publicity, we were getting a little bit of spotlight to show the public what we've been doing in terms of COVID-19 research. And in return, we were obviously playing the role of the scientist that would, support the message from the public administration and from the politicians that everybody should get vaccinated. Because they did not have a majority, they could not enforce mandatory vaccination, but they wanted to use, everything possible to convince the public to get vaccinated. And in Germany, the vaccination rates are not that great. So they wanted to have, in a sense, more more people to convince the public, and they wanted to have me as a independent scientist, having standing there in front of the cameras with a PhD and university medical center, basically saying get vaccinated, and that was the deal. I mean, that was not explicit, but implicitly, that was the deal. We would get spotlight, media coverage, and in return, we would support the political aim of increasing vaccination coverage. And for me, that was very interesting. It was, I have to say, I am working on committees that advise politicians, but this is all behind the scenes in radiation epidemiology. So normally I'm used to, having meetings with other scientists, and then there is a representative from the ministry, for example, for the environment is present. We discuss stuff, and then there's a protocol, and the politicians use our advice or not. But this is not part of, newspaper coverage. And this was different because my role as a scientist was, in a sense, less neutral. And I had to decide if I wanted to play the game, in a sense. If I was, um, if I felt confident of being, in a sense, used to promote a message. But we talked about this, and we thought that given that the message to get more people vaccinated was a good one, we can do it without losing, in a sense, our scientific credibility. And I was also not asked to change my talk. So nobody had access to my talk, and nobody asked me to include certain points in my talk or to remove certain points from my talk. And so I had, I was very independent in preparing the presentation, and that was actually very nice that they had this confidence that I wouldn't do anything stupid, in a sense. And so that was, in a sense, to also talk to the public and talk to other politicians. And what was to me interesting in a sense of personal experience, because I'm not used to talking with the prime minister. This was the first time that I was meeting somebody on a higher level of political decision making. And we had a little talk before the presentation to get to know each other. And what was interesting to me is that everything happens very, very fast when you go into politics. For example, doing the press release from our publication inside University Medical Center, that was a long process. So we talked to our public relations guys. It takes a couple of days until they answer an email. Then we send a suggestion for a press release, then it takes a couple of days until they get back, and then there's some back and forth. And there is basically enough time to think about everything. Now with the politics, with the politicians here, I had 3 days to prepare my presentation and also do a little handout for the journalists. And then when I came to the presentation to this press conference, I was given a new press release that the ministry wanted to release to the public. And I had 3 minutes to go over the press release and make sure that everything was correct. And that was important because not everything was correct. They didn't really understand the type of analysis we did. So there were some gross misstatements in the press release. For example, in the press release, they wanted to show to the journalists, there was a statement that we showed that the COVID-19 mortality rate declined from 70% to 14% in the age group 80 plus. And that's not what we've shown. And so I had only 3 minutes, in a high stress environment, because I was also very nervous before giving the presentation, to make sure that, nothing embarrassing will be published. And the same happened after the presentation, because I was then immediately after the presentation, I was contacted by the social media team from the ministry, who basically put me in front of camera and said, could you please sum up your study in 30 seconds? Here you go. And I was like, it's difficult enough to write a 10-page publication that will do the study justice. It's more difficult to give a 10-minute presentation, and now you want me to sum up everything in 30 seconds. But that's how the game is played, basically. So I had to do it. In the follow-up of this was also interesting because for the first time, I've seen that the public attention span is extremely short. So after the press release, and there was also news coverage in a couple of newspapers, but that lasted a day. Nobody has talked about our study in public since that day when the press release and the other coverage was released. So basically, the public attention span, it is so short. There is new stuff coming up every millisecond, and even though you are in the spotlight in one instant, nobody will think or talk about you 10 minutes later. That was also a very interesting experience. And that's the end of my talk. Thank you.